Depuis maintenant près de 6 ans, j'accompagne des femmes du monde entier vers le docteur Véronikis pour retirer des bandelettes pour incontinence et des implants de mèche qui ont bouleversé leur vie. Et à chaque fois, je vois des sourires renaître, des regards qui s'éclairent et des corps et des vies réparés. Ce podcast, c'est plus que des témoignages. C'est un hommage à leur courage et à l'homme qui redonne l'espoir un geste à la fois. Alors écoutez pour mieux comprendre et surtout partagez, en hommage à toutes ces femmes et à celui qui change des vies dans l'ombre depuis toujours. Bienvenue dans la saison 2, dans la maison des Améchés. Thank you, doctor, to take time to come to explain the surgery of Isabelle. She's a lucky one that she never had a mesh, so we wish that to each woman. So first of all, just to the benefit of the woman they watch my podcast, can you tell me who you are, how long you performing on this kind of repair without mesh, and what specialty someone need to do that?
So, of course, I'm Dr. Véronikis, right?
I know, but
my training started in 1990 in general surgery, and then I did obstetrics and gynecology, and then I did a subspecialty in what they call urogynecology. And my area of training and expertise is in vaginal surgery. You can be a urogynecologist and do laparoscopy or use the robot, but my expertise and my training was in vaginal surgery, and I trained with Dr. Nichols, who wrote the book on vaginal surgery.
Okay, so can you give me just a small explanation of the difference of you and a urologist or a gynecologist?
So a urologist treats men and women. A gynecologist spends their entire career, taking care of women. From the time that these women have their first pap smear to the time they have their first baby, the gynecologist experiences the trauma of childbirth and understands what happens to the pelvic floor, what happens to the woman during pregnancy, and how they recover. And a gynecologist might do a hysterectomy, but a gynecologist these days mostly focuses on taking care of women. Some do some surgery. A urogynecologist specializes in the care of women that have surgical problems. And some of those problems are prolapse and incontinence, and that's actually a very small portion. My practice starts with making vaginas for women that are born without one, to taking care of complications from surgery, whether that's recurrent incontinence, whether it's recurrent prolapse, whether it's fistulas, whether it's a fistula from childbirth, or complications with mesh that try to improve the woman's life, but actually sometimes, many times, takes it in a bad direction.
Okay, so it's very a specialty, like very, very precise. You only take care of women and almost do only surgery.
Essentially, I am in the operating room 18 days a month out of 20.
Good. So you repair without mesh. So it's your specialty. So can you tell me a little bit more about the surgery of Isabelle, because she had a good prolapse, if we can say it like that, and she was not incontinent when she came, but with the UDE, you discovered that she was incontinent. So give me a little bit of information, very simply, for the woman, that they know how you repair without mesh.
Sure. So just for Isabelle, she had prolapse, and the prolapse masked the incontinence.
Okay. But can you explain that a little bit?
The best way to explain it simplistically is that the prolapse puts a kink in the urethra. So the prolapse is at a lower point. So when the woman coughs, she does not leak. But when you fix the prolapse and put the vagina and the pelvic organs back in position, the kink is eliminated, and now the woman discovers painfully that she leaks after surgery.
Okay, so it's why some women, they have, in France, they have this kind of promotofixation plus a sling.
Sometimes.
Okay.
I don't put in any slings unless the woman has diagnosis of incontinence on objective testing called urodynamics. So every woman that presents with incontinence, I look for prolapse. Every woman that has prolapse, I look for concealed incontinence.
So, okay, so that in the case of Isabel, so she had the prolapse, we did the UroDE. Can you explain how it works?
The urodynamics essentially measures the function of the bladder and the urethra during emptying and storage. Losing urine when you cough is a failure of the urethra to hold the urine in position. There's also urgent continence, but that's typically a bladder contraction, and that is not treated with a sling.
Okay, so tell me how you repair without mesh. So it's not like a promotofixation, thing like that. So she had zero plastic in the body and she had a sling. So can you tell how you do that?
Sure. Essentially, you reverse the damage that's occurred with childbirth.
So this is the baby who broke the vagina, if we can say it like that?
Yes. Humans have a big head. They're cranially dominant. And something has to break. And it's the woman's pelvis that is prepared during pregnancy to allow the baby to pass through. But when those tissues stretch, they don't always come back.
Okay.
And sometimes there's trauma, torn muscles, ligaments. So essentially, vaginal surgery is restoring the anatomic relationships that exist. That means taking organs that are stretched and putting them back. So you're using the physics of the design of the human body to replace the prolapse.
Okay, so Isabel told me, and I like it, she told me that she had a dropped bladder. So they all said that my bladder dropped. My bladder was outside of my vagina. See, it's what she said though. So, and you told her, no, your bladder it's not your bladder, and she was surprised. So can you explain a little bit for the woman?
Sure. There's no such thing as a drop bladder. Okay? The bladder is an organ that is internal. The anterior vaginal wall is like a retaining wall. If you have bricks or rocks and then you have a garden behind it, those rocks are like the vaginal wall, and it keeps everything in position. When the vaginal wall drops, the bladder goes with it. Same with the rectum. When the perineum and the posterior vaginal wall is disrupted from the episiotomy or the tears from childbirth, and the vagina moves out, the rectum is attached, it moves with it. So there's anterior vaginal wall prolapse, and the bladder goes with it. There's posterior vaginal wall prolapse, and the rectum goes with it. And that's just a simplistic explanation of a very complex three-dimensional organ called the vagina and the supports. But the only normal operation we have for fixing prolapse is to refix those structures and realign them back to normal. That way you restore the anatomy, you restore the function, you restore the physiology. And in that way, you don't create a problem with using plastic or mesh by doing that.
So can you tell me how you do that? So you do plicature, or you just simply?
Simply.
Yes.
So there are very specific spaces in the female pelvis. And in vaginal surgery, we find those spaces, and we do surgery within those spaces which are avascular. There's no blood vessels. So there's the rectovaginal space, the vescovaginal space, the pararectal space, the paravaginal space. So you find those spaces and you separate the structures and you take out the stretch.
Okay.
And then when the vagina is stretched, you tailor it, and that is an art. And how much do you tailor? Too much can cause a problem. Too little, you get prolapse because it's not fixed adequately.
Okay.
So when you find these spaces, there's no nerve damage, there's very little bleeding, there's very little pain, and it is the way that vaginal surgery is performed.
So don't need anything except to do surgery.
That's correct. You
Yes.
restore the organs, and the more you restore them to normal, the better position they are. Then the woman can harness that energy when she coughs, and it keeps things in place instead of pushing them out.
Understand. Do this repair last in the time?
They do last.
Yes.
It's nothing.
Because I see a lot on Facebook page that it doesn't work. It's not enough strong, and maybe it's why they use plastic in other countries.
So there's very few studies that look at a comprehensive reconstructive repair. Okay. The only thing that's 100% success is a hysterectomy. One does not grow back.
No.
Other than that, okay, doing a complete repair where you fix and find the endothelial. So if a woman has an endothelial, it should be fixed. Fix the rectocele, the perineum, the anterior vaginal wall, the cystocele, the anterior vaginal wall. When you do all that, you have a better chance of having a long-term success. Obviously, there are things that can traumatize and make the repair fail. Chronic constipation, chronic lifting, okay, an inadequate repair, and an incomplete repair.
Yes. So we see often a woman appear here. She had a cystocele repair, and she still have prolapse of like a rectocele.
So a cystocele repair is not a complete prolapse. And if you read Dr. Nichols' book, which I know you have, right? There's a displacement and a distension cystocele. A distension is left to right, and that's what an anterior repair does. A displacement, okay, is when the cervix comes down. That is an apical problem. So fixing one aspect of the anterior vaginal wall prolapse does not fix the other. So that's where you must also fix the apical prolapse and the anterior vaginal wall. And that's still not enough. What you do to the top, you have to do to the bottom. What you do to the bottom, you have to do to the top to balance the repair so that it works like a flap valve. So when the woman coughs or lifts, everything supports itself normally.
Do you have a simple example, just short example to have a visualization of that?
So a vagina is a three-dimensional structure. You can't fix one wall or another wall. You start with a foundation. If you have a house that's falling, you pick it up, you fix the foundation, and then you fix every layer along the way.
Yes. So it seems simple.
In theory, it's simple, but in execution, it's complex. Pelvic organ prolapse is a complex structure, and there's no two women that have the same surgery. You must make the operation fit the patient's needs.
Tailor for the patient.
Yes, you must tailor for the patient.
Yes.
It's
They're all different.
Exactly. You can't do the same thing the same way. That will only give you poor outcomes.
Okay. So, but when they have incontinence, you use a sling. So, what is a sling? Because they said, use sling. What is a sling? What kind of tissue is it? Or can you use the tissue of the home patient? It's all that I want you to talk about that.
Absolutely. The first sling was described in 1907. And for many years, there were no synthetic slings. So slings have been around for a very long time. Sling is the best operation. It works the best. You don't have to use mesh or plastic. You can use fascia. You can even use muscle. There are some surgeries described in the German literature. Just use muscle. But fascia works better.
What is a fascia?
Fascia is a strong membrane that supports muscles in position. It's also like a retaining wall, okay? It keeps muscles in position.
Okay.
And you can use fascia from the abdomen. The best fascia is to use from the leg because of the orientation of the fibers, and it is much stronger. The orientation of the fibers on the abdomen are oblique, and it's not as good, quite simply. It's not as good.
Tell me, what is the difference? Because you don't use the own fascia. You use the own fascia of the patient if they they want. But you use another kind of fascia. Can you tell me a little bit about that?
So I very much like fascia lata. It has the best long-term outcomes. Sometimes the patient does not want her own tissues to be used. Sometimes she wants her own tissues to be used. So if I harvest fascia lata,
So it means that if you take a piece of the own
I take a
fascia,
piece.
yes,
There's two ways to do it. You can make an incision,
yes,
okay? Or I was also trained to use a Masson fascial stripper. And you make a little incision, and it's like a guillotine effect, and you can remove a good piece for sacrocolpopexy, what you call promental fixation, or a smaller piece for a sling. There can be some pain, and if it's a young woman and she wants to run, you have to tell her there's a possibility to have pain. Some women do not want a scar on their legs. They like to wear shorts. So if they don't want their own fascia, the alternative is to use fascia that is biologic. It's still fascia lata. The DNA's been removed, and it works just as good. Actually, a little bit better because the fresh fascia has a higher retention rate.
yes. What is the meaning of that?
Means that because there's a lot of force from the leg muscles on the fascia is always in a balance with the muscles. When you walk, the muscles contract. When you remove that fascia and you put it under the urethra, you have to leave it a lot looser. And even when you do, because there's not enough pressure from the urethra, the fascia shrinks and has a higher potential for inability to urinate. And you have to adjust it.
You know what I like when you talk about the jeans you put in a dryer.
Yes.
Yes.
Yes. So if you harvest your own fascia, it's like the jeans that are not pre-washed, pre-shrunk.
Yes.
When it's the biologic, because it's been prepped, it is like jeans that have been pre-shrunk. So you can set the tension more precisely.
Yes. So it's more precise and less retention.
Correct.
Yes. The last question maybe, and do that simple because, I know that it's very complicated. Why in France they use more promotofixation and they don't repair the vagina like you do? So it's my question. So there is so many promotofixation in France that I don't see in Canada, Quebec, if I can say Quebec. Why? Can you explain that to me? What is the difference and why?
Well, I choose to fix the vaginal walls naturally. Okay? Native tissue repair. What I've seen is that the women that have the promental fixations in France, the mesh goes all the way down to almost the urethra and all the way down to the perineum. So they're trying to fix the walls by putting mesh in there. You can do a promental fixation, only keep it at the top, which is what I do, but I use fascia for that. I don't know why they do that, but it is a tremendous amount of mesh. I've never seen mesh like that placed in a woman's pelvis before.
And they come here and they still have prolapse.
Yes.
So you don't use laparoscopy like a lot of other doctors. Why?
Well, you cannot fix prolapse vaginally with a laparoscope. Meaning that the laparoscope might be beneficial for doing a hysterectomy, maybe, but you cannot fix the vaginal walls, the perineum, with a laparoscope. You cannot really do a sling with a laparoscope. It is much more invasive to use laparoscopy. But the simple answer is, if you use laparoscopy as your technique or the robot as your technique, the way you're going to fix the prolapse is with a promental fixation or a hysteropexy. If your technique is vaginal surgery, you can do a hysteropexy vaginally, but most of the time it's a hysterectomy with repair of the apex, repair of the interseal, repair the cystocele, repair the rectocele, fix the vaginal walls, take the stretch out of the vagina and make it normal again, fix the perineum, fix the vaginal opening. And the only way to do that is vaginally, not with a laparoscope.
So it's not possible to do that kind of surgery with a laparoscopy or robot?
So laparoscopy is an application of a technology. I have an application of a technique. So if you have a technique that works, you really don't need the technology.
But a lot of surgeons, they said that they can do a vaginal repair and a prolapse repair by laparoscopy. What do you think about that?
I think it's ridiculous. Ridiculous. Plain and simple, ridiculous.
Okay.
You have a woman who has a rectocele. It's the least invasive approach, the safest approach, the most direct approach to fix the problem that you see in front of you. If you proceed laparoscopically, you can't even see really what you're fixing. You can't see whether you're reconstructing the organ the way it should be, whether you can't see the perineal muscles, you can't put them together, you can't fix the opening. Plus, there's a lot more risk with laparoscopy. Every laparoscopic surgery carries the risk of a defect in the abdominal wall with a hernia. Every laparoscopic surgery, even though it's very low, it's not zero, carries the risk of trauma to the bowel, carries the risk of trauma to the blood vessels. Okay, so those are not complications that you have at all with fixing a rectocele, for example, vaginally, and you see it right in front of you. It's less invasive than laparoscopy.
Why they said that laparoscopy is less invasive?
No, they don't say what they say. The comparison is to open abdominal surgery. So if open abdominal surgery is maximally invasive, okay? And remind me, I want to say something about that. Mm-hmm. And laparoscopic surgery or robotic surgery is minimally invasive.
Yes.
That's a comparison with the incision.
Okay.
So if you can fix the rectocele and not have all the trocars, right? Mm-hmm. Then if minimally invasive surgery is laparoscopy and you can fix it vaginally with no laparoscopy, then vaginal surgery must be non-invasive, right? Mm-hmm. And when it comes to fixing prolapse with a promental fixation, mm-hmm. what they tell you is they can do it minimally invasively with mesh, but it is maximally disruptive to the architecture of the pelvis. You have to move the bowel out of the way. You put mesh all the way down. It might be stuck on the lateral sidewall, on the veins, on the ureter. It wraps around the uterus. It destroys the spaces and the way that the pelvis works. Though the pelvis is not meant to be fixed and rigid. That's why some women have pain. It's meant to be flexible. When the woman coughs, things move. It's like being in your car. You like metaphors.
Yes, I like that.
Being in your car and you hit bumps. And it's very gentle. Now imagine if you had pieces of steel and you hit those bumps, what it would feel like.
It's not comfortable.
So vaginal surgery is non-invasive compared to laparoscopy, because if laparoscopy and robot surgery is minimally invasive, right, and an incision is maximally invasive, then vaginal surgery must be zero invasive. What can I say more?
Nothing more.
It's the truth.
All that said, what is your last recommendation for the woman that had prolapse or incontinence and all that kind of problem?
There are techniques, and then there are techniques. Technology is not always a better option over a technique that uses natural tissue. And the woman should ask questions, make sure she's comfortable, do your homework.
So this is the price to have children. So
exactly. Exactly. If you don't have children, you don't have these problems. It's something that is uniquely a problem of the women, our mothers that bring us into the world, the price they pay. And they should have high volume surgeons with great outcomes and techniques that don't cause problems.
Thank you, Dr. Merci d'avoir été présent. Merci à mes invités d'avoir partagé leur expérience. Suivez-moi sur ma page Facebook L'Expérience Améché et mettez vos commentaires sur la vidéo. Un gros merci. Bye!